Welcome to part 2 of the Peer Support and Perinatal Mental Health Training Series. In this training, Raquel and I will discuss ethics and boundaries, barriers to care, addressing perinatal mental health conditions, self-care practices, and our fabulous guest speaker, Faith Hale. Listed on the screen is a review of our community care practices. These were also discussed in greater detail in part 1 of this training series. We also have provided the key terms and definitions that have been discussed in part 1 and 2 of this training series. If you need a recap on the key terms and definitions we will be discussing, feel free to pause this video and take a look.
Peer specialists have lived experience similar to those of their target population, which helps them to understand and directly relate to those they are supporting. This is a different and important nuance from clinical care. The Policy Center for Maternal Mental Health, 2022. Beyond having lived experience, there are certain functions or practices that shape the way in which peer support is provided. Peer support is non-clinical, relationship-based support from someone with lived experience, often including one or more of the following components. Emotional support. So this is expressing empathy, care, and togetherness. Informational support. This might include care navigation and referral to health and wellness supports, sharing information of resources. Instrumental support. Similar to informational, this involves providing access to concrete resources and wellness supports. Affiliation. This type of support involves connecting individuals with community activities and events. It emphasizes the communal aspect of care. All aspects of peer support, regardless of practice or setting, should embody the collective values and principles of trauma-informed care. Agency, safety, choice, collaboration, trust, cultural humility. A trauma-informed approach to care seeks to create a safe and supportive environment, recognizing the impact of trauma on an individual's life. Care is then responsive to individual needs, differences, and unique experiences. Individuals are trusted as the experts of their own lives. We are the guide, a support, and a collaborator in care. As I mentioned in part 1 of this training series, the peer model is designed to complement and enhance the work of traditional providers, not compete or replace. Peer supporters can mitigate provider shortages, often bridging the gap in care when there are long wait times and getting connected to a therapist or counselor. Peer supporters can also help reduce stigma and shame surrounding mental health. Not everyone is as comfortable speaking with a clinician about their mental health challenges as they might be in speaking with another mom or birthing person who has gone through similar experiences. This is especially true for those who may have mistrust in healthcare systems, as the same power dynamics and imbalances may not exist in peer models of care. While the benefits to peer support are truly boundless, it's important to clarify the ethics and boundaries of this work. Peer support should not be confused with your typical friendship, even if there is a feeling of friendship in the peer relationship. Peers should operate within their scope. This means refraining from giving medical advice or diagnosing. If someone is in need of medical care or support beyond a peer's capacity, they should consult and refer to someone equipped to provide that level of care. Peers should abide by the guidelines of HIPAA, similar to nurses and other licensed professionals. Information disclosed by moms and birthing persons receiving peer support should be considered protected health information. Always respect privacy and protect the confidentiality of the individuals you are working with. This applies to your notes as well. Take notes that are objective and non-judgmental. Be aware of your personal biases and ability to provide inclusive care. When providing peer support, you will often encounter individuals with backgrounds, beliefs, and lived experiences different than your own. Consider how your biases may impact the care you provide. If a situation feels challenging, intense, or new for you, reach out to a supervisor or colleague to debrief and consult around the best course of action. Lastly, remember that peer support can be heavy and that there may be times that someone else's experience may trigger hard memories of your own connection with perinatal mental health. Be aware of your triggers and know when to step back. We encourage peer supporters to be in a place in their recovery where sharing their story feels purposeful, not pressured, and grounded in a desire to support others on their journey.
Those who use substances have higher rates of children's service involvement and lower rates of reunification compared to those who do not use substances. When a child is born with substance exposure, Children's Services is often alerted by hospital staff. They come and do an assessment while the mother is still in the hospital or the child is still in the hospital. This assessment covers much more than substance use. It also addresses housing, needed resources, mental health, and safety within the home. There are different ways Children's Services can become involved with a family, and not all of them include removing the child from the care of the parents. An open case is when a Children's Services agency undergoes an investigation, and this may or may not involve removing the child from the care of the parent. After removing the child from the care of a parent, they could be placed with kinship or with family or within a foster home. A family is assigned a caseworker who will work with the family during the open case. A case plan will be provided to the family and will list what the family must complete for reunification or for the case to be closed. A safety plan works to address safety and stability within the home. Children's Services will provide resources and guidance until safety is restored, and then the plan is complete. Safety plans do not address the custody of the child. A plan of safe care is a formal plan for treatment and care when a child is born with substance exposure or the family reports substance use. This can accompany a safety plan or a case plan. It does not address the custody of the child. It is a policy that any child born within the United States must receive a plan of safe care regardless if a case is open or not. A common question I receive is related to when should Children's Services become involved. This can be a challenging and difficult topic to discuss. Most county-level children's service agencies will not open up an investigation during pregnancy. Some counties have programs that will provide resources to hopefully prevent an open case after the birth of the child, but there are few in Ohio. The only county in central Ohio that offers this service is Fairfield County at the moment. After a child is born, there are a few ways to assess a situation. Did I witness physical abuse or neglect? Was I shown physical evidence of abuse and neglect, like a video or photo? Is the child or children in immediate danger? If the answer is yes to any of these questions, then you must make a report to Children's Services. Other questions to ask yourself: what can I do within my role to help the family? What resources can I provide? What is my company's policy surrounding reporting? Technically, anyone in the state of Ohio can make a call to Children's Services at any time. And I will say, I have been working with this population for nearly a decade, and I have only made one report to Children's Services ever. Listed on the screen are strategies regarding screening for perinatal mental health and substance use. It is important to remember when providing screening that screening needs to be universal and given to every client or patient. It needs to not be based on suspicion. Ideally, screening should not be a one-time thing. I understand that there are certain roles where you may only have one contact with a client or a patient. If you have the capacity to do so, conduct screenings on a regular basis. Situations change and clients may become more comfortable with you as you work together. Screening should be administered in someone's native language and in a way that they understand. Ideally, language should not exceed a fifth grade reading level. Mental health and trauma should be taken into consideration for screening for substance use. Urine toxicology does not count as a screening. You cannot assess someone's mental health or trauma from a urine drug screening. Screening should be culturally competent and trauma informed. And it is important to mention that somebody's substance use is their personal, private health information, and it must be protected.
As previously mentioned, effective screening is about how you screen, which is why we don't endorse a particular screening tool. There are benefits and challenges to most tools, and your rationale for choosing one over the other will rely upon the setting in which you provide peer support, as well as the needs of the people you work with. What's more important in screening is the environment you create. Is there trust and rapport between you and the person you're screening? Is it an ongoing conversation and collaborative experience, or a one-time Q&A? Are you able to personalize the screening process based on the unique needs of each mom and birthing person you work with? Culturally responsive perinatal mental health screening is sensitive and adaptive to the cultural contexts and lived experiences of Black and POC birthing persons, as well as others whose cultural identity or community experiences shape how they give and receive care. That said, culturally responsive screening is a beneficial way to screen all moms and birthing persons, as no two people share the exact same lived experience. We recommend 5 key steps or strategies to get you started. 1. Foster an atmosphere of trust and safety. While safety can be subjective, you can increase the likelihood that an environment be perceived as safe by another. Your demeanor, language, and attitude can impact a person's perception of safety. Consider your facial expressions and reactions. Does your posture present as warm and inviting, or cold and standoffish? If you're unsure, practice with a friend or in the mirror beforehand to ensure you are outwardly presenting in alignment with your good intentions. 2. And really throughout the entire screening process, make it a conversation. Offer validation, normalizing fears, concerns, and thoughts expressed by the mom or birthing person. Remember to listen actively, repeating back what you heard, often to ensure clarity and shared understanding of what's being expressed. Use person-first language, as well as language that is inclusive and non-judgmental. 3. Providing choice and transparency when screening. Moms and birthing persons should always lead their plan of care. Openly discuss the screening process and present all options for continued care, giving mom and birthing persons plenty of choice. Folks are most likely to engage in the care that feels most feasible to them. There must be self-willingness. We should not force or push. 4. Discussing the results. When discussing the results of a screening or assessment, be mindful to communicate a positive screening score with empathy. Remind the mom or birthing person that a positive score is not a diagnosis. It's just a sign that they might need some additional support and care, and that's okay. Reaffirm that PMHCs are treatable and that there are plenty of options for care, and you can help them sort those options out. 5. If mom or birthing person needs additional help beyond the peer support you are providing, request their consent in making a referral. This continues to build trust. Be clear about your next steps, what parts of their information might be shared, where it will be shared, and how. Within 1 to 2 weeks of making a referral, follow up with the mom or birthing person to ensure they get connected to their desired resource. If not, see if you can help them in any way to do so. This might involve reaching out to the referral source directly or supporting mom or birthing person with scheduling. The only exception to getting consent from mom or birthing person and making a referral is when there is a safety risk or expressed harm to self or others. Let every mom and birthing person know when you begin working with them that there are certain situations that may require you to break confidentiality. We will discuss safety risk and how to navigate those situations later on in this session. Quality perinatal mental health support should involve both screening and referral. Screening alone does not result in perinatal mental health or perinatal substance use treatment and recovery. Imagine feeling overwhelmed and stressed with a daunting to-do list ahead of you. You have so much to do but don't know where to begin. This feeling is paralyzing, and rather than doing anything, you just do nothing. This is how I felt when I had my daughter and was struggling postpartum. I knew I needed help, but I had no clue where to find it. I was given a packet of resources from our pediatrician, but couldn't bring myself to call any of them. Sorting through the list, assessing my eligibility for certain services, and whether or not my insurance would accept any of them was just too much for me. As peer supporters, we have the opportunity to alleviate this burden for moms and birthing persons, taking one more to-do off their list. Instead of leaving them with a list of numbers to call, we can work closely with them to learn their needs and preferences and connect them directly to the support best matched to those needs. Every mom and birthing person has unique needs, a personal history, and preferences that should be addressed when identifying treatment and support options. Depending on the circumstances, they may engage with one or more of the following supports. Peer support, such as a mom-to-mom or birthing person support group. Self-care and social support, such as planned time away just for themselves with the help of a close family member or friend. Medical interventions, so this could include taking prescribed antidepressants or other medications in consultation with their primary care provider. Behavioral interventions, such as attending individual therapy or counseling. Evidence-based SUD or substance use disorder treatment. Ashley will cover this in more depth in the next few slides. Always, the best option for someone is often the one that is most accessible to them. Encourage practical actions. Support them in coping with their emotions. And consider their life situation and navigate care accordingly. Peer support should always reflect choice-centered care. When discussing mental health challenges with a mom or birthing person, validate their strengths. Ask open-ended questions. Relate with empathy. Reflect what is expressed back to them. Ask permission to explore options of care. And partner on a plan together. Most importantly, listen. Active listening involves identifying. So this might sound like, hey, you say that you're angry, but I hear you laughing. What's going on for you? Reflecting. This might sound like, it sounds like you might be feeling, and then you'd fill in the blank, and ensure that your understanding is what they said. Similarly, clarifying. Hey, I think you're saying that you're feeling this. Do I understand you correctly? Giving them the opportunity to clarify and create shared language with you. Exploring. Is this a new feeling or familiar one? So you're really gauging how often these feelings occur for that mom or birthing person, and if this is something that they're used to dealing with. And then summarizing. So let's go over what we've talked about so far. You said that, fill in the blank, is that right? And this is where you might partner on a plan together of care and treatment. As you're going through these conversations and discussing next plans of care and action, really try to resist interrogation and asking why questions. Though well-intended, those questions can come off as judgmental, right? So maybe what or how, but avoid saying why. And if you don't know what to say, know that that's okay too. Sometimes the best thing we can do is just give space and respect silence. Allowing time for people to process their feelings and emotions can go a long way.
On the screen are a list of compassionate care strategies. I am going to highlight perinatal harm reduction and motivational interviewing today. Perinatal harm reduction is reducing harm from substances by providing alternatives and interventions. Examples of perinatal harm reduction include providing Narcan and fentanyl test strips to clients or patients. If you do not have these resources available to you at your organization, you could always give clients resources on where they can obtain things like Narcan and fentanyl test strips, like the whole local health department, for example. Celebrating the small wins. Maybe somebody used less of a substance. Maybe they quit one substance that they were really struggling with. It's really important to celebrate any milestone. Progress is progress. Remembering that not everyone is ready for treatment, and some people may not ever be ready for treatment, and you have to be okay with that. Providing other resources like clothing and food. People have to have basic survival resources. We have to be able to have a place to sleep at night, regular food to eat, clothes on our back. We have to have those things before we can make decisions like entering treatment. Otherwise, we're just going to stay stuck in survival mode. Motivational interviewing. Motivational interviewing is influencing a client's desire to seek change through conversation guided by the individual. Put the ball in their court. What change, if any, do they want to make? How can you help? Foster an environment where they feel safe, they feel understood, and they feel supported. Never force your desires or opinions on the individual. This is their story. It's not yours. Interventions to address perinatal substance use disorder. I have a whole separate training discussing pregnancy, substance use, and treatment. If you are interested in this training, you can contact me by phone or email. My contact information is listed at the end of this training, and it was also listed at the end of part one. I want to start out by saying treatment is not a one size fits all approach. There are many different pathways to treatment. Listed here on the screen are some examples of different treatment interventions that are available to the pregnant population. There is medication for opiate use disorder for those who have an opiate use, which includes using substances like fentanyl or painkillers. This includes the use of Suboxone or methadone within a setting that provides these medications that are supervised under medical staff. There's also the use of inpatient treatment that may or may not involve detox and includes a stay of anywhere between 3 days to 90 days. There are also long-term residential programs that involve staying overnight in a treatment program, and this can be anywhere from 90 days to even 18 months long. There are also outpatient programs like my program at CompDrug, which involve somebody receiving treatment services during the day and going home and sleeping at night and completing their everyday life activities. There are things like counseling that include individual counseling, groups, intensive outpatient treatment, and even higher levels of outpatient treatment like partial hospitalization, which, fun fact, have nothing to do with a hospital. There are also other organizations that provide recovery support and a sense of community. This could be communities like Narcotics Anonymous, Alcoholics Anonymous, various different 12-step recovery programs, smart recovery, and even recovery meetings within religious institutions.
We can't talk about screening and assessment for perinatal mental health complications or perinatal substance use without talking about safety assessment. Similar to screening and assessment, we want to assess for suicidal thoughts and safety often, right? Suicidal thoughts can fluctuate and vary in duration and intensity throughout the perinatal period. Normalize and validate any feelings of anxiety and depression. And don't be afraid to ask specific and direct questions. It's okay to ask someone, are you having thoughts of harming yourself or others? When we're asking these questions, remember to distinguish intrusive thoughts from higher risk symptoms of psychosis. Intrusive thoughts about self or baby are not plans to harm. So consider the following questions. Is the mom or birthing person distressed by these thoughts? So remember, we talked about ego dystonic versus ego syntonic. If mom or birthing person is distressed by these thoughts, that is typically a sign that these are intrusive thoughts, may be associated with obsessive compulsive disorder, and not a sign of psychosis. Do they recognize these thoughts as their own? And are there other signs of psychosis, such as hallucinations or delusional thinking? If so, then we might consider it a medical emergency. If there is identified safety risk, whether it be psychosis or non-psychosis, right? So even if there's risk of self-harm due to suicidal thoughts with plans and intent to harm themselves, we want to take some actions, right? First, we don't want to leave them alone until additional support is secured. So do we have the contact of a close family member or friend or someone to come be with that mom or birthing person if we are not available? Can we contact that trusted family member or friend, right? Do you have consent to do so? Support them in securing childcare if they have other children if necessary. So maybe they need to go to the hospital for a time to get the care that they need. Who is going to watch their kids while they're gone? And can you help them find a safe place for their kids to be? Create a safety plan that includes follow-up, right? So maybe this is a plan detailing next steps for when they have thoughts of harming themselves. So maybe you come up with this plan at a time that they don't have these thoughts, but they know that they might have a pattern or a tendency to. So you work ahead of that even to come up with a plan of care. If it's actively happening in the moment, again, this plan of care could involve contacting a trusted family member or friend, ensuring that they have childcare if other children are involved, any other things that they might need help with. Maybe this is contacting their job or place of employment, things like that. Anything you can do to alleviate their worries or the things that might be preventing them from getting the care that they need. And of course, if the situation feels very intense, you're not sure what to do, know that you don't have to do it alone. I highly encourage you to consult and debrief with your supervisor or a colleague, especially when making these decisions. It can be overwhelming, right, to support someone going through this, especially if it's your first time. So know that you don't have to do it alone. You can consult. You can debrief. You can find out next course of action with the help of others. While there's really no perfect formula for knowing the risk of safety for someone, there is a general rule or set of guidelines to follow to help you in making these discernments or judgments as far as knowing when to call in additional levels of care and support for someone, okay? So know that again, a lot of this relies on conversations with the mom or birthing person. This is really about building trust, rapport, really having an understanding of how that mom or birthing person talks about mental health. Maybe they won't directly say that, hey, I am suicidal, but maybe they're expressing thoughts of worthlessness, right? Man, I feel like I don't want to be here anymore, or I don't think my baby needs me as a mother anymore, or maybe I just want to go to sleep and never wake up, right? So we have to be mindful of how people talk about mental health and really be curious about what they mean by those things and ask those questions. But typically the general guidelines as far as level of risk is as follows. So we consider someone low risk of harm to themselves or others when that person has no plan. So maybe there's expressed thoughts or ideations, but no plan. So at that point, we might consider this person low risk. This would be still a great opportunity to develop a care plan for them as far as how to cope with those emotions when they feel them, who can they contact, who do they trust, who can they rely on for that additional support to buffer when navigating those feelings or those suicidal ideations. Risk increases to moderate when this person may have a plan but no intent to act. So maybe they do know what they would do, but they're clear in that they wouldn't do it, right? There's no plan or intent. Or there's a plan, but there's no intent to, right? And they're very clear and adamant about that. Still, right, we want to create safety measures to support this person, even in this position, but they might not need a call for hospitalization, right? You might not need to escalate it to that level if they're still at this low to moderate risk. Risk does significantly increase to high, where we might want to make a call to a crisis professional if they have a plan, intent, and access to implement that plan. So this is someone who has access to weapons, to pills, things of that nature, and they share that with you. That is when, we will want to engage with a higher level of care. So there's different resources, right? We know we have the National Suicide Prevention Lifeline, 988. We do have the National Maternal Mental Health Hotline, 1833 TLC Mama, that's 852-6262. Note that those crisis calls, though, will be rerouted to 988. At certain times. And then there's a crisis text line, 741-741. And then here in Columbus, Ohio specifically, one thing I want to call out is that when possible, consider alternative crisis response options that may be available in your area. So we've talked a lot about equity and inclusion throughout both parts of the training series. And one thing I want to bring to you all is the consideration of what is safe and safe to whom. So unwarranted experiences with the police and or involuntary hospitalizations can be traumatic, right? Especially for Black and POC individuals who have historically and currently are experiencing more harm from police, healthcare systems, etc. So that could be a thing preventing someone from receiving the care that they need. Maybe they know that they need that additional higher level of care, but they're scared to call the police because what that means for them existing in a Black body, right? We also need to be mindful of those calls and consider that when creating a support system for someone. So when possible, there's alternative crisis response teams that might not involve law enforcement and might instead send out like a social worker, a community health worker, someone who might be a little bit better equipped to de-escalate a situation and might present as safer for that mom or birthing person, depending on the situation, right? So consider that when we are also assessing safety and deciding to move forward. There's no perfect solution or formula on what to do, but always consult. And if you have questions, don't be afraid to reach out to someone for support so you don't have to go about it alone. The self-care conversation. So one disclaimer that I'd like to share before we talk about self-care for peers, which is essential to this work, is that I recognize that we cannot self-care our way through trauma, right? So reference this image here shared on the slide, the self-care iceberg. There's one way that we have really started to think about self-care widely in society, and that could be exercise, bubble baths, skincare, spa days, massages, getting your nails done. Those things can be self-care. However, when we are working with crisis, with emotionally heavy work, with trauma, self-care can tend to be, the need of that self-care can be deeper, right? Self-care can also include trauma healing, that inner child healing, working with a therapist, setting clear boundaries, knowing to step back, reset, little rituals throughout your day, maybe meditation, learning your own triggers and when and how to navigate those, right? Vicarious trauma is very real, especially in the work of peer support, which is so inherently tied to our even own lived experience. So just own that, accept that, and honor it, right? As a peer supporter, take care of yourself and know the signs of burnout. This might look like exhaustion, right? A level of exhaustion that can't be repaired through any amount of sleep, right? This is fatigue in your body, in your spirit, mental and emotional fatigue. Burnout can also look like irritability. Maybe you're annoyed by things that didn't typically annoy you in your job a month, 2 months, a year ago, right? As that irritability grows, you might also experience emotional numbing or apathy. So, that feeling of caring less maybe about your work or the impact it's having, not really feeling connected to the mission or goal. Again, these feelings are normal and they can come up when you are providing peer support, especially, right? So, that is why it's important to take care of yourself. Try daily check ins with yourself. So, knowing your personal limits. Be honest, have conversations. Maybe you have a conversation with your supervisor or a colleague that is dedicated to checking in on your mental and emotional regulation. Where are you? What's the temp, the vibe check, so to speak, of how you're feeling and how you're showing up in your work? Have there been particularly challenging cases or scenarios that you've been dealing with that are, landing heavier on you? You can't shake them at night. You're thinking about them even beyond your work setting, right? Learning to let go. Again, mentioning those peer debriefs, they can be really helpful as far as expressing and regulating and sharing some of the emotions that might come up for you, especially when they come up unexpectedly. We could be 10 years in our recovery journey and then one day something triggers us out of nowhere. It happens and that's okay. Talk about it so it doesn't build up inside and store in your body, in your heart, in your mind. And also create healthy routines and boundaries. So again, maybe that looks like knowing that every day at 5 p.m. you don't open your computer anymore, right? You know that at that time you are leaving work where work is. Not answering certain calls or connecting in the peer work on the weekend or on a certain day of the week. Knowing what works for you and your lifestyle and being very firm in those boundaries can help you maintain a healthy relationship to peer support and providing it. At the end of the day, peers are the most effective in encouraging self-care if they are nurturing themselves in their own lives. So again, I don't say that to be cliche or really minimize the impact of self-care. It can be exercise, it can be spa days, and all those good things. But really take self-care seriously and know that you cannot pour from an empty cup. So prioritize your own well-being, know your triggers, engage in therapy or counseling or whatever you need to do to be the best version of you for others, right? Again, we encourage peers to be in a place of their own recovery where sharing their journey feels purposeful and not pressured, right? So I encourage you to do what you need to do, right? To care for yourself so you can care for others. To conclude our perinatal peer training series, we'd like to take time to hear from Faith Hale. Faith brings both lived experience and professional dedication to her work in behavioral health and peer support. As a single mother who has personally navigated the challenges of perinatal mental health and recovery, she has transformed her journey into a powerful commitment to helping others find healing, stability, and hope. Today, she works closely with mothers in recovery in a residential program that houses women together with their children and prioritizes pregnant women and mothers of children under the age of 2. In her role as a peer and behavioral health specialist with integrated services, Faith supports individuals through a trauma-informed, recovery-focused lens, meeting them where they are with empathy, honesty, and persistence. Faith's personal passion lies in expanding the reach of peer support, particularly for pregnant and postpartum individuals navigating mental health and substance use recovery. Let's hear from Faith.
Hello, everyone. Thank you so much for having me today. I'm honored to share a bit about my journey and the work I do with perinatal mental health and substance use peer support. My story started when I was using prescription painkillers at 19. My introduction to addiction came through relationships. I didn't even realize I was addicted until I was already too deep in it. I was in and out of sobriety for years, and then I found out I was pregnant. I quit using at 7 months, mostly out of the fear that someone would take my child away from me. My pregnancy was full of fear and shame. I felt stuck. I seriously considered abortion at first because I didn't want to bring a child into what I felt like was a broken situation. But I had my son, a beautiful 7 pound, 6 ounce boy. I named him Zane. After he was born, I relapsed. But then I made a choice. I got on Suboxone and eventually transitioned to Sublocade. And from there, I began to build a real foundation. Today, I have full custody of Zane, and I'm close to finishing my bachelor's degree in sociology. I have worked as a START peer mentor with Children's Services, and now I serve as community behavioral health worker and a peer at Groundwork Sober Living. I became the support I once needed, and that's what drives everything I do today. In that regard, we have to talk about ethics and boundaries of peer work. One of the most important things I've learned as a peer supporter is that my presence doesn't mean taking on someone else's pain. It means walking alongside them with boundaries in place. I keep emotional boundaries. I don't absorb everything I hear or try to fix people. I protect my time. I don't take calls outside of work hours unless it's an emergency. And most importantly, I protect my own recovery because if I'm not well, I can't support anyone else. Supervision, mentorship, or personal reflection keep me grounded. One of my core beliefs is this: comfort is the enemy of progress. That's something I tell myself and my clients often. Growth happens when we're willing to step out of what feels safe and familiar. However, sometimes we face systematic barriers and care inequalities. Supporting patients who are facing both the child welfare involvement and with substance use is deeply personal to me because I've been there. I remember being terrified that my child would be taken from me. And that is a fear, that fear is very real for so many people that I support. I approach them with empathy, not as a professional who's above them, but as someone who knows what it's like to feel powerless. I help them understand their case plans, prepare for meetings, and advocate for themselves. Advocacy is everything. I often say to my clients, I don't want anything from you. I just want you to succeed. And once they see that, once they realize that I'm on their team, that's when trust starts to form. Rapport comes from honesty, consistency, and advocacy. We're not just giving support, we're showing up. We're standing beside them when systems fail. With this, intervention comes along. So, what actually works when you're supporting someone who's navigating perinatal substance use or mental health struggles? Sharing lived experience. People trust me because I'm not just trained, I've walked it. Strength-based language is super important, reminding them of what's already working in their lives. Also, motivational interviewing, not pushing them to change, but helping them to find their own reason to. And just showing up, literally. I make calls with them, attend appointments, and walk them through the fear. Peer support is about presence more than perfection. It's about saying, I've been there and you're not alone. We have to have compassion in this for ourselves and for others. Compassion for others and ourselves is what makes peer support real. I used to struggle with shame about what I'd done, what I've been through, but I learned that if I couldn't forgive myself, I couldn't show up fully for others. Self-compassion helps me stay grounded. And for my clients, compassion often means simply holding space, not judging, not rushing, just being with them and their experience. Most people don't need advice first. They need to feel safe. In this, I commonly practice self-care and healing practices. Peer work can be incredibly rewarding, but it can also be emotionally heavy. I've had to learn what keeps me grounded. I go to church and journal often. That's where I process. I spend time in nature, walk, or just slow down when life feels overwhelming. I also love to take trips to the beach. It makes me feel closer to God. I surround myself with others, peers, and people who just get it. I've learned to say no when I need to because I can't give from an empty place. Healing is ongoing for us and for the people that we serve. If I could share one thing with someone just starting out in perinatal peer work, it's this: lead with your heart, but protect it with boundaries. Show up consistently. Presence builds trust faster than anything else. You don't need to have all the answers. Just be honest, be human, be real. This work is not about saving people. It's about walking beside them until they're strong enough to keep walking on their own. I became the person I once needed, and now I get to be that for others. Recovery is possible. Parenting in recovery is possible. Nobody has to walk through it alone. Thank you all so much for letting me share today. I'm proud to be a part of this work, and I hope my story reminds someone out there that healing is not only possible, but it's powerful.
Ashley, Faith, and I thank you again for joining us for Part 2, Peer Support in Perinatal Mental Health. It's our hope that today's session will support you as you move forward with your perinatal peer support journey. If you'd like to connect with POEM, Perinatal Linkage to Care, or Integrated Services for Behavioral Health, please reach out by phone or email at the contacts provided here today. If you'd like to learn more about the specific services offered by each program, refer back to Part 1 of this training series, Perinatal Mental Health 101, where Ashley and I discuss the POEM program and perinatal linkage to care in more depth. Again, thank you, and always remember to care for yourself in this work.